Thank you, Dr. Anand. Now we are about to start the keynote lecture session, where we have a privilege. We are privileged to have a stalwart of the spine surgery of the country, Professor Atul Goel and Professor Shashank Kale. For this session, I would like to invite our chairpersons. Professor Dilip Sen Gupta is a renowned spine surgeon from the Texas, USA. Professor Rajkumar Deshpande is an eminent spine surgeon of the country, Director of the Department of Neurosurgery, Fortis, Bangalore. Professor Avdesh Jaiswal, Department of Neurosurgery, SGPGI, Lucknow. Professor Atul Goel is a world-renowned authority in the field of the CV junction and spine. It will take me a whole day to enlist his achievement. But briefly, he has won the multiple prestigious awards from all around the world in the field of neurosurgery. And some of the prestigious awards I must mention: Eminent Medical Teacher, Dr. B.C. Roy National Award, Dandy Medal for Distinguished Neurosurgical Service, International Ambassador Award by Congress of Neurological Surgeons, and many more. He is credited with the 23 patents and approximately 700 publications. He is currently the president of 4 prestigious national and international societies and editor of many national and international journals. He is a professor and head of department, KEM Hospital, Mumbai. Now it is my honor and privilege to invite Professor Atul Goel, sir, to give us insight on his revolutionary concept about the decompression versus stabilization in the spine surgery. Goel, sir.
Okay, Jayesh, you can see my slide?
Yes, sir, yes.
Okay. So I am indeed going to present to you a revolution. And I am indeed going to present to you something different. And I am going to present to you whatever is published and published in high-profile journals. I am saying that the entire psyche, entire attitude of spine surgeons in general is decompression. And I am saying that this decompression is not necessary. Quite a dramatic statement to make, and let me see how I can prove this point. So I am saying, look beyond decompression. I am going to introduce to you a new concept in entire spine surgery. Of course, tumors and all are different. Instability is the issue. Instability is the primary factor, and rest, whatever happens, is all secondary. If you have heard the previous lectures also, we do stabilization following decompression because we think that our decompression can destabilize the spine, and in future this spine can become unstable. So we do stabilization. That is the general understanding in the current literature. So this is the human body. We are standing human position. Horse runs on 4 legs. There is not much pressure on the back. This bird flies on the wings. There is not much pressure on the back, but this human standing position is the problem. And you see the huge muscles this man has, but normally we don't have that kind of muscles. And our standing position throughout the life is maintained by our muscles of the back muscles. My concept is clear. that if your back muscles become weak, your spine becomes unstable. And the concept is, if your muscles of the spine become weak because you have disused, you have abused, or you have injured, you cause vertical spinal instability, which may not be even seen by radiology, and it is the point of genesis of your entire problems of spinal degeneration. This is basilar invagination. We all know. You may, of course, know that 20 years ago, this entity was considered to be a fixed entity, and the whole world used to do either transoral decompression or foramen magnum decompression. We introduced the concept that there is a possibility of realignment of the craniovertebral junction, and there is no need for decompression. Fixation was recommended by some people during that time, 20 years ago, because transoral decompression was considered to be a destabilizing factor. So instability was not a primary issue. So we introduced the concept that basilar invagination is not a primary bone abnormality. It is secondary to vertical spinal instability due to your muscles of the back problem. Like this is the basilar invagination. Now you know there is no need for any decompression. You have to do stabilization. So this concept we introduced about 20 years ago, and believe me, there was a lot of resistance to accept this fact. This was the first case in the year 2000 where we said that there is no need to do decompression, there is a need to do fixation. And most of the people doing craniovertebral junction now realize that this entity of basilar invagination should be treated by stabilization and by realignment. Rotatory atlantoaxial decompression, 20 years ago, nobody in the world knew how to treat this kind of problem. And if you see the literature, the whole literature is focused on decompression of the spine. So in about 20 years ago, we introduced this concept that you open the joint, realign the facet, manually manipulate the facet, and you can realign and you can give a new neck. So multiple, we have done several patients like this, like open the joint, manipulate the facet. There is no need for decompression, essentially. This kind of post-traumatic, when the facets are disrupted, the only treatment that was recommended was decompression. So we said that there is no need for decompression. You can manipulate and stabilize and realign the facets. There was a very well-known entity called fixed atlantoaxial instability or irreducible atlantoaxial instability. Every literature was mentioning about fixed and the need for treatment by decompression. So we all know that there is a possibility of reduction of this dislocation. There is never an entity of fixed atlantoaxial instability. So in flexion extension, there is no movement. Transoral decompression was the treatment. And because transoral was destabilizing, some people preferred fixation. Now we know that we can reduce. There is no need for decompression, either from front or from behind, and you can stabilize the spine. As you know, we have got multiple of hundreds of these kind of patients. Basilar invagination is due to vertical spinal instability due to your muscles of the back of the neck, and instability is the problem, and stabilization is the treatment. There is no role for any kind of decompression, and I have no hesitation to say that we completely demolished transoral surgery from the domain of craniovertebral junction surgery. Facets are the issues. Facet is the fulcrum of all movements of the spine. We introduced the concept that lumbosacral listhesis is a problem of facetal instability. Similarly, basilar invagination is a problem of facets and instability of C1 over C2 21 years ago, and we recommended that when there is a listhesis of C1 over C2 and there are problems at the craniovertebral junction, there is a problem of instability, there is no need for decompression either from front or from behind, and you have to do stabilization. Then we introduced probably an absolutely revolutionary concept of central atlantoaxial instability. You see, this is the listhesis of C1 over C2 that I mentioned, and there is atlantodental interval disturbance, there is compression of the cord. Listhesis is the problem. We know that it is unstable, and we know that the treatment is C1, C2 fixation. This kind of basilar invagination, the treatment was decompression, nothing else. And till date, I think very few people in the world talk about stabilization. And you see there is a facetal malalignment. And you believe me, one thing I am telling you, you believe what I'm saying. If you respect me, if you love me and like me the way you have praised, you believe what I am saying, that this is an unstable situation and this needs stabilization. There is absolutely no need for decompression. Revolution, not today, but tomorrow it will certainly be recognized by the world of spine surgeons that even when there is no facetal malalignment, presence of Chiari, presence of basilar invagination, presence of syringomyelia are absolutely clear indicators of an unstable craniovertebral junction meriting the need for stabilization. There is no need for decompression. So there's basilar invagination is an outcome of atlantoaxial instability, and we have now published several articles stating that in basilar invagination, whether it is group A, whether it is group B, only fixation is the treatment. So when there is no atlantodental interval disturbance, there can be facetal malalignment type 2, and there can be only one treatment of stabilization. And you see whether the syringe goes or not, that is very minuscule of all results. Patient will improve dramatically, to say the least. Whenever there is no facetal malalignment, but there are other features of the craniovertebral junction which suggest posterior fossa tight is a theory which I introduced in 1997, that posterior fossa is tight in the Chiari malformation. I am saying my own theory is not good. The problem is not tight posterior fossa, it is unstable spine. And as you know, now we have hundreds of these patients with Chiari and syrinx where there is atlantoaxial dislocation, and atlantoaxial stabilization is the treatment. And syringomyelia will reduce in 100% of cases if you do a scan after 1 year. And there is no need for discussion on this. And there is controversy if you have, there are only two ways. Either you come to my department and have a view for, and there is no harm. People are coming from all over the world. People from India can certainly come. So basilar invagination, syringomyelia, and Chiari malformation are all secondary to atlantoaxial instability. And as you know, atlantoaxial stabilization is the treatment. I published a series of 388 cases. And if you read this article, you will say absolutely clear. The problem is that Chiari malformation is a protective phenomena, and Chiari malformation is an indicator of atlantoaxial instability. There are many other indicators of atlantoaxial instability, and they are all protective. Cervical fusion is an indicator of atlantoaxial instability, is a protective natural response. Bifid is an indicator of atlantoaxial instability, is a protective natural response. It is a dynamic phenomena. When you see multiple fusions, when you see bifid, there is only one understanding, and absolutely clear, there is no need for any decompression. There is a need for C1, C2 stabilization, even when there is no compression at the craniovertebral junction. Compression word and decompression words should be removed from this kind of. Os odontoideum is a natural protection, and all these sentences which I'm saying are published sentences. When there is atlantoaxial instability, transoral decompression, which is done in the Western world still. Occipitocervical fixation is still done in the Western world. Absolutely not necessary. It is an unstable spine. C1, C2 fixation is mandatory. Syringomyelia is an indicator of atlantoaxial instability. It is a secondary phenomena, is protective. Idiopathic syrinx is a protective phenomena indicating atlantoaxial instability. You have to treat and you have to give new life. And in the immediate postoperative period, new life to the patient. Syringomyelia will disappear in 100% of cases. All musculoskeletal abnormalities are secondary to atlantoaxial instability. Torticollis, short neck, kyphoscoliosis, and various other musculoskeletal platybasia are all indicators of atlantoaxial instability, and they are all protective. Short neck, spasm of the neck muscles. You do atlantoaxial stabilization and you get this smile in the immediate postoperative period with a tall and straight neck. Even if the smile is not so good, but the neck is long and big, what I have done is no decompression, no osteotomy, only fixation of the problem. And problem is atlantoaxial instability. And you have to believe there is no need for decompression of any kind. Kyphoscoliosis. The whole world is doing 200 screws and 1 kilometer of rod and fixation. I am saying that kyphoscoliosis of this kind is 100% not primary problem, is 100% due to atlantoaxial instability. And you do atlantoaxial stabilization, you create a normal spine. And to do multiple fixation is not necessary. Maybe controversial, maybe too radical a statement, but you believe what I'm saying. Atlantoaxial instability is the cause of craniovertebral junction. You see this kind of kyphoscoliosis, if you start manipulating the spine and start putting screws and all, you have damaged the person, and you have damaged the person very badly, and you have damaged and you have created harm for the patient. So you can, this kind of neck deformity, spine problems, many of them, most of them, or all of them are due to atlantoaxial instability, and you can make kings out of these kind of people. There is an entity of central dislocation where there is no compression, but there are other telltale evidences which indicate the presence of instability, and you have to immediately give new life to these patients, and you can, and you should, and you will have to. This patient who has, you see, you can see immediate post-op, the hand is moving only this is central atlantoaxial instability. You see the shoulder, the dressing has not been removed, and there is a complete realignment. You ask me whether foramen magnum decompression is historical. Absolutely, absolutely. And you have to understand why. Now I'm going to take you to another world, an absolutely revolution in spine surgery. You see, I have been talking about anterior surgery. I have got a chapter in Sweet and Smedek, and I have done various kinds of fixation. I introduced these tricortical screws, and I was very familiar with cervical, anterior cervical fixation. Now I introduce to you a brand new concept. The whole problem of spinal degeneration is not the disc. It is not the disc. Disc is divine. You have to pray the disc, and you have to respect the disc. The problem is you. Problem is your own body. Problem is that you have not exercised your muscle. You have not done yogas. You have not run. You have not jogged. Muscles become weak. You think you are retired. Your muscles become weak. And that is the beginning of your problems. Craniovertebral junction instability. Nobody had worked, but craniovertebral junction instability is the most common instability and degeneration. This bone formation is not primary. Now you see carefully this slide, my dear young and old friends. This kind of buckling of the posterior longitudinal ligament is due to vertical spinal instability. There is no problem with the posterior longitudinal ligament. Reduction of the disc space, right? Reduction of the joint space is no problem with the joint. It is due to the weakness of the muscles. Osteophyte formation, this is not a disease. This is a protective, natural protective phenomena due to muscle weakness. So please see this slide, because the rest of my lecture will depend on that. This kind of apical ligament bone formation is not a primary issue. Don't go and decompress this. This is an indicator of atlantoaxial instability. You have to do stabilization. Retroodontoid ligamentous hypertrophy or pseudotumor is a clear, absolutely clear indicator of an unstable atlantoaxial joint. And I published this absolutely landmark paper where I said there is no need to decompress from front. no need to decompress from behind. You do atlantoaxial stabilization, this will disappear. And this I published in 2004, and I think this is complete revolution. And we said that retroodontoid ligamentous hypertrophy or pseudotumor is like an osteophyte. Even these cysts are not primary. They are indicators of unstable atlantoaxial. You stabilize, cyst goes. There's no need, even if it is such a simple procedure to puncture the cyst, it is not necessary. And we have got several cases where these kind of cysts have not been touched, even though you know that I can easily go and puncture this. But this you do stabilization and the matter is closed. This is another case where the cyst is not touched and it indicates a beautiful unstable spine. You see, this is a os odontoideum. There is a cyst behind the C2. And you see there is a bone cyst. There is, I published this paper where I said that there is a kind of a siphoning, and you do flexion, the retroodontoid thing goes inside and outside. And this is a protective phenomena. So this cyst is a protection. It is not harmful. Similarly, this kind of a retroodontoid soft tissue formation, there is bone formation. I published this saying that there is a movement of this cyst, and this is a protective phenomena, indicates atlantoaxial instability and need for stabilization. So you can go through these sentences in my articles, which are all published. Retroodontoid pannus, which is the whole world used to remove by transoral decompression, and then somebody used to do posterior fixation. I have said this is due to buckling of ligament and due to weakness of the muscles. You do stabilization, and there is no need for removal of pannus and a protective phenomena. So I introduced intra-articular spacers for the first time in the literature, and you know these are very popular for craniovertebral junction. And now I talk about spacers in the cervical spine, and you please listen to the concept which I'm going to give you. You see, like C1, C2 instability, we have never discussed about the facetal instability of the cervical and the lumbar spine. You see reduction of the disc space, bulging of the posterior longitudinal ligament, osteophyte formation, multiple bulges are not primary phenomena, are not problems. They are indicators of an unstable spine. They are indicators of the need for stabilization, and there is no need to remove these things, which is absolutely clear, and the vertical instability is the problem. I am telling you about my history. I introduced the concept of intra-articular spacers, which is now a very popular concept. You introduce the spacers and you reduce the posterior longitudinal ligament bulge and you increase the disc space. More importantly, you dramatically improve the patient. So this facetal listhesis is the primary issue. Facetal, you see multiple posterior bulges and ligamental bulges. I have not decompressed at all. I have done facetal distraction, and you see the whole spine has become normal. More important than that, the patient remarkably, you have to believe this, remarkably completely improved in the post-operative period. This kind of osteophyte, you distract and you give new life to the patient. And you can do multiple level for single level, radiculopathy, myelopathy, and all kinds of things. You ultimately what you need is you have to need arthrodesis or fusion of the affected cervical segments. You see multi-level disc prolapses, and I have done multi-level stabilization and arthrodesis, and this disc disappears, and this disappears in very quick time. So you see, this is, I have done multi-level facetal distraction, which I am telling you, which I don't do now. I am going to tell you what I do now. You see, this is facetal disc space. Facetal space reduction is the primary issue. Disc space reduction is the secondary issue. Ligamentous bulging, a secondary issue. Osteophyte formation is the secondary issue. You distract, you stabilize. Primary, secondary issues need not be touched, and they are all protective, and they are all secondary. You see this disc bulge, and this is gone. More important is the stabilization. And now I have, you see, these are my earlier cases, several patients. So this is a concept. Concept is that decompression is not necessary. Compression is not a problem. Problem is instability, and you need to stabilize. So this was published as cover page of Journal of Neurosurgery, and this concept is introduced a new hypothesis of spinal degeneration, that this degeneration is not the primary problem. And these were the spaces which I introduced, and there are several patents. I have got 23 patents for this problem, both Indian and international. So this is another thing. You see, you can have reversal of disc herniation if you do fascial distraction. This is a huge disc herniation. The whole world will come and do discoidectomy, anterior surgery, and all. You must also do. Unless you are convinced, don't do it. But there is an immediate reduction of the problem by fascial distraction. Same concept we use for the lumbar spine, and there is, for lumbar canal stenosis, we introduce intra-articular spacers, and I published this about 11 years or 12 years ago in my experience with 21 cases. Now I go to another concept. The whole world thinks that decompression of compressed or deformed neural system has been the basis of treatment for several decades, and you all agree. And I'm saying that it is not the compression, it is instability, and you have to treat instability by stabilization and not decompression. And I have published this very thoroughly in literature. This is in World Neurosurgery. The title is Muscle Weakness Related Spinal Instability is the Cause of Spinal Degeneration, and spinal stabilization is the treatment, no decompression. And I have got, you see, there are videos, but I don't have time to tell you how this patient will say that I have got new life, doctor, and there is a multi-level compression. No, no, don't use the word compression. These are divine intervention. These are protective phenomena, and you do only stabilization. They are indicators of an unstable spine, and you have to identify. Most important in this is which segments are unstable. You see, there is multi-level herniation. The immediate post-operatively, this is gone, and you see the neck movements. And you have to, another thing is, believe me, new life for the patient for his entire. You see another multi-level compression and spinal issues, and you see the whole spine. I have done only fixation arthrodesis. There is a video here saying, doctor, I'm having a new life, but this video I don't have time to show you. There's another large osteophyte here, and I have not done any decompression either from front or from behind. I have done this transarticular camealized technique of fixation, and I have no hesitation to say that a revolution in treatment has been made. You see this multi-level, as we have already heard, the treatment is multi-level corpectomy or discoidectomy or posterior decompression. I am saying absolutely no. I am saying not necessary. You see, this is post-operative, and the whole system has changed, and the whole system is new. More importantly, I have not decompressed, only fixation. And the most important thing is patient getting new life. So degenerative cervical spinal myelopathy or radiculopathy is a problem of instability, and the treatment is stabilization, and there is treatment of decompression. This word decompression is not necessary. You take this sentence from me. It is not neural deformation or compression, but instability is the cause of symptoms. You stabilize and the symptoms are gone. Most important is you have to find which segments to fuse, and that is a very critical issue. You see, there is this kind of compression, and you see after about 6 months of surgery, there is fusion, and this compression is automatically disappeared. The treatment is not dysphagia. Don't cause dysphagia. If you go for you can cause various problems. We know that, and we have heard that. Treatment is stabilization, and you have to change your psyche. You see, you change your psyche. It's difficult for me to go on repeating, but I'm saying a revolution has been made. You see, multi-level compression.
Hello, Goel sir.
These are divine interventions, protective interventions, stabilize God says, I don't need any more protection. Everything's clear and patient. This is fusion.
Goel, sir.
As I mentioned, I've got hundreds of patients like this who have been cured. And when I say hundreds of patients, I say for sure 100% improvement. Now, if I say 100% improvement, if you find one patient who has not improved, in you, these patients keep on roaming around, you let me know, and I will then see how I have to protect myself. You see, there is this kind of intervention. And
Dr. Goel, I think you are being asked by the moderator. We all believe you.
Please note down, in multi-level spinal degeneration, atlantoaxial instability is a common phenomenon, is an absolutely, we ignore it. And I can tell you, you see this multi-level, you see the facetal instability, I can tell you, no compression does not mean that you do not stabilize the atlantoaxial joint. You stabilize and you see wonders. You see magic, and believe that magic. You see multi-level problem, and there is no issue in the craniovertebral junction, atlanto mild, marginal here, no compression. You have to. And if you don't, you have not cured. This patient can be cured by atlantoaxial and subaxial stabilization without decompression. So when there is cervical spondylosis with severe myelopathy, atlantoaxial instability is almost always present, and you have to do atlantoaxial stabilization even when there is no compression. So don't use the word compression. Don't use the word decompression. Instability is the issue. Where is the instability? Find out. So C1, C2 can be stabilized by alternative technique, which you must read from my paper. There is multi-level. There is no compression here in the atlantoaxial joint, not much in the C2, 3, and C4, but I have fused those. Identify which segments are unstable, and you have to fuse. That is the issue. Identify which segments. These are not, all are not primary issues. These are secondary to an unstable spine, and it needs stabilization, and it needs multi-level stabilization, and you are just waiting for wonders to be seen. You see multi-level, this is ligamentum flavum bulging, and you see it is gone, and I have fixed, and I have not done indirect decompression by facetal decompression also. You see the title, lumbar canal stenosis. This is a neurosurgical focus, analyzing the role of stabilization and futility of decompression. So I'm saying don't decompress. When you see these kind of bulges and these kind of indentations, these are not primary problem. They indicate unstable spine, even when nobody in the world has said this. And I am saying on the firm conviction that if you want to cure your patient, if you want to give him new life, and there is no need for decompression. And now I have got hundreds of these patients. I didn't talk about it for 10 years because I didn't want to introduce criticism and backlash and all those kind of things. Now, after 10 years, after about 200 publications on these kind of things, where I have said that all these are unstable issues, you stabilize and you give new life. So these does not need decompression either from front or from behind. It needs only stabilization and only fixation. The bottom line is identify which segments are unstable and which segments have to be fused, and you will see multiple articles of mine. Is it necessary to remove the osteophytes? The whole spine surgeons want to remove this osteophyte. I am saying it is not necessary. I am saying it is harmful. You stabilize, the osteophyte will disappear. And I have published this article in World Neurosurgery. After 12 months, what is the outcome when only fixation is done? You please read that article. Problem is you don't want to read my articles or Indian articles. If this same concept was told to you by Harms or by some other American person, you would have said, yeah, very good, very good. But when I say this, you try to find faults and you try to find criticism. You find to degrade and degenerate this idea. Don't do that, because you will ultimately fail. You see this multi-level osteophytes, you stabilize and the osteophytes will disappear. And this is a fact. More important is the patient will improve in the immediate postoperative period. More important is which segments are unstable. Only compression does not mean that is the only segment. There are adjoining segments which are unstable and need to be stabilized. So you see these multi-level fusions. Whether we should call it spinal stenosis, I am saying this word is not good and it gives you a wrong direction of treatment. You should say multi-level stabilization is, multi-level instability is the issue. This kind of kyphosis, don't do osteotomies and decompression. This is unstable due to atlantoaxial instability. This kind of kyphoscoliosis is unstable due to multi-level degenerative level instability. It needs stabilization. So no osteotomy and no decompression for kyphoscoliosis. This kyphosis or kyphoscoliosis, this article is also going to be published very soon, where I have said this kyphoscoliosis is a result of an unstable spine and it needs stabilization. Now I introduce another dramatic, absolute dramatic, and probably a quite a in your mind, not in my mind, that prolapsed disc hernia or herniation is a result of an unstable spine. Whether the disc herniation is a result of unstable spine or herniated disc causes unstable spine, it is the unstable spine which has to be treated. You have to do only stabilization. So in cervical, if this kind of disc is there, the whole world, definitely there is no confusion, come and do ACDF and all those things. But this is a result of an unstable spine, and this is a cause of unstable spine. You wear cervical collar. Why you wear cervical collar? Because you want to stabilize it. You do neck movement, it pains. So you stabilize and the disc will disappear eventually. And you see the result. You see the magic. You see this is the disc herniation. This disc has gone. And I'm saying, whatever I'm saying is all published in high-profile journals. And this is facetal arthrodesis as treatment of cervical radiculopathy. Similarly, lumbar disc, can you believe? You will not believe. You should not believe. And you, if you believe, you will be criticized very thoroughly if you do not remove this disc by microdiscectomy or oblique discectomy or all kind of discectomy. I'm saying you do only fixation and you see the magic. You see the magic and you see the disc will disappear eventually, and it has to disappear without any doubt. But problem is you have to do solid fixation. You see the disc herniation and the disc is disappeared. More important is the patient will recover dramatically. In the evening of operation, he will say, "Doctor, what pain? I don't know pain." And now I am talking about a big experience, long experience. I have told you already, I am doing this is for 'Is like retroodontoid pseudotumor, is a result of instability. Ossification, I was doing myself, but multi-level corpectomy and all, and you might have read my article, which is the first time in the literature in neurology India I published oblique corpectomy. You don't want to refer my articles because if there is some American, you immediately want to refer that. But you will not refer limited oblique. This is described by me. This oblique corpectomy, you see, cut from here, and you do this decompression was described by me. I am saying now, and I am saying positively, you will not refer, but you try to understand and hear at least. And if you have doubt, you come to my department. I'm not far away from any other place in India or any in the world when there are hundreds, more than 300 international fellows have come to me. I am saying that OPLL is a result of atlantoaxial instability and cervical instability, and stabilization is the treatment. This kind of OPLL, don't do decompression, don't do laminoplasty, don't do laminectomy, don't do corpectomy, which are negative. You do only fixation and see the magic. Problem is, you have to, and this is very heavily published and very heavily cited article, is only stabilization the ideal treatment for OPLL? I'm saying yes. And I am saying absolutely yes. And I am saying on the basis of publications and on the basis of citations. When there is OPLL, no need for decompression. Many of these patients have central instability. You do stabilization of atlantoaxial joint, which is mandatory. If you don't do, and laugh it away. Laugh it away. Yeah, Goel is saying this and Goel is saying that. Laugh it away. No need to laugh. Try to understand and try to, if you have doubts, come and see. And if you want to, if you don't want to, unless you are waiting for people like Harms and people like other Americans to say, then only I will agree. Then you wait, please wait for another 15 years, because these concepts will not come for a long time. You see this OPLL, and these are stabilization. And I don't want to show you the videos because of the time issue. This is only stabilization. The OPLL will eventually disappear. So my concept is atlantoaxial and subaxial cervical fixation. Can it revolutionize the treatment of OPLL and cervical myelopathy? Yes, and absolutely. This Camille's technique, which was very little used in the literature, I have used it very elaborately. I have little bit modified this technique in lumbar spine, where I use 2 screws or double insurance screws. Sometimes I use 3 screws or triple insurance screws. The final slides are, can decompressive laminectomy? Can this word decompression? Can this word compression? You see, spine, the nerves are like rubber band. They can increase in length. Compression is not the issue. Compression is never the issue. Instability is the nodal point of pathogenesis of degeneration and OPLN, and stabilization is the treatment. Like I demolished transoral surgery, like I'm going to demolish foramen magnum surgery, I'm saying today, and you see it after 10 years, that I will demolish anterior cervical surgery, and I will demolish the possibility of dysphagia that you are talking about, and I'm demolishing the possibility of injury to recurrent laryngeal nerve and all kinds of tools that you are talking about. This kind of laminectomy, laminoplasty, anterior instrumentation, it will be completely historical. And in my department for last 12 years, these kind of operations new set was bought earlier, and that new set has remained untouched. From only decompression to only fixation, this has taken a century-long treatment of cervical degeneration. Atlantoaxial and subaxial fixation completely revolutionizing the treatment. So final comments is, compression is never primary. Decompression is never the treatment. So this is from one patient of mine, and I call it my enlightenment. Means I've got an idea. I have got a bright idea. I have got divine intervention in my head. And world of spine who are listening today, better listen to it before you want to wait for some other international person to give you these concepts. Thank you very much.
Thank you. Thank you very much, sir, for this multiple revolutionary and game-changing concept of the decades, which I'm sure, like me, has left the live audience across the world mesmerized. It's always been a pleasure to hear you, sir. Thank you.